So it is 10 o'clock on the dot, so we will get started. I know we'll probably still have a few people trickling in, but I'll get started with the welcome and some housekeeping items. So hello, my name is Bethany Friedrichsen, and I am the statewide coordinator for relink.org. Today, we wanted to welcome you to Adolescents and Addiction, Strategies for Treatment and Recovery. We're grateful to be partnering this morning with Akron Children's Hospital to put on this webinar. A little about relink.org. We're a nonprofit started in 2017 in Northeast Ohio. We are operating statewide though. Our desire is to use technology to connect those in need due to addiction to the resources in their community. We also make an effort to constantly be involved within the community through outreach and education such as this webinar today. So I will be facilitating. If anybody has any issues, please message me directly in the chat or email me at the email on your screen right now. Just a couple items. We have almost 100 participants registered for today, and we are so excited about that. We have people from all over the state that are going to be joining us. With so many of you, we want to make sure we use everyone's time wisely. When you join the webinar, you're muted and we cannot see you, so the best way to communicate with us is either through the chat or the Q&A. I will be monitoring questions throughout to ask our presenters at the end during the Q&A, so please put them in there. If there are a lot of questions, which is what we always hope for, and we start to run out of time, don't worry. I will send your questions to our presenters afterwards so that I can send their responses in the follow-up email. Everyone who registered will receive a follow-up email by the end of the day tomorrow with the presenters' slides, any information that's given out during the presentation, and a small certificate of participation. So you will get that by the end of the day tomorrow. As I said, if anybody has any questions, please let me know. And without further ado, I will pass this along to our Executive Director, Barbara Campbell, who's going to introduce our speakers today. Thank you.
Thank you, Bethany, and good morning and welcome to everybody. We are really excited to get to partner with Akron Children's Hospital to bring you this webinar today. I know at relink.org it has been one of our absolute passions to not only provide the best data for addiction recovery and reentry services for the whole state, but to really connect and get involved with the community. And in 2020, that was our goal before COVID started. And then we got a big challenge of how do we get involved in the community when we can't actually be around the community. But Bethany and her team has done an incredible job of using the Zoom platform to connect and stay really embedded in the community. And this is one of those webinars. This topic to me is such a heartbreaking topic. Addiction in general, obviously, is devastating our state, but when it affects children at such a young age, it just so drastically affects the trajectory of their life. And so I think we're really blessed to have two wonderful speakers with us today. We thank you for taking your time out. Getting to know them, we know how busy they are. So we are really thrilled to have you. What I'm going to do is introduce both speakers right now at the beginning, and then I'm going to turn it over to Talia first, who then will turn it over to Dr. Goldman, and then we'll follow up with some questions and answers. So first today, we have with us Talia Brown, and she is serving as the program coordinator for addiction services of the Division of Pediatric Psychiatry and Psychology there at Akron Children's Hospital. She completed her bachelor's degree in sociology in 2008, and then her master's degree as a community counselor at the University of Akron. She's a licensed professional clinical counsel supervisor and a licensed independent chemical dependency counselor and clinical supervisor, and she has 9 years of counseling experience, both with adults and children. She uses an eclectic blend of cognitive behavioral therapy, motivational interviewing, and dialectical behavioral therapy to help patients to their journey, on their journey to recovery. So we're really thrilled to have her today. And in addition, we have Dr. William Goldman, who is a physician at Akron Children's Hospital. He completed his undergraduate studies at the University of Georgia and then went to medical school at the Chicago College of Osteopathic Medicine at Midwestern University in Chicago. He completed a residency in general pediatrics at the Medical Center in Akron, and he did a fellowship with addiction medicine at St. Vincent's Charity Medical Center. He is board certified by the American Board of Preventive Health and Addiction Medicine and the American Board of Pediatrics. He is currently serving as the medical director of Addiction Services Program and Behavioral Health Addiction Services there at Akron Children's Hospital. So I feel amazingly blessed to have this education level here to share what they are seeing and what they are learning with us. So without further ado, Talia, I will turn it over to you.
Yes,
Thank you, Barbara.
And I will just stop the sharing, turn this over to, so Dr. Goldman can get his presentation up. Go ahead, Talia, sorry.
Thank you, that's okay. Thank you everybody for joining us this morning. Dr. Goldman and I work tirelessly to provide outpatient treatment, including individual and family counseling, medication-assisted treatment, and withdrawal management for adolescents up to age 18 who struggle with substance use disorders. We actually hit the ground running this past May when our outpatient clinic went live. We're really thankful and fortunate that COVID didn't derail the plans to get the program up and running, just to give us the ability to provide evidence-based care for youth on their journey to recovery. Dr. Goldman is very passionate and knowledgeable when it comes to adolescent substance use treatment. And as he always says, adolescents are not little adults. So without further ado, I present Dr. Goldman, our program medical director, as the keynote speaker for today to discuss the intricacies of adolescent substance use treatment.
There you go. Now I've unmuted myself so everybody gets to hear my voice. Thank you, Talia. Thank you, everybody. You know, I don't know. I still don't like to hear about myself, but give me 1 second. Let me pull this up. So yeah, my name is William Goldman. Little background, which was shared. I kind of got started never thinking I would do this in my life. I actually thought of myself, maybe I went into general pediatrics. I thought about becoming a developmental pediatrician, but life takes changes. And, you know, for me, that moment first arrived, I was working in Akron Children's in the emergency department. And I had a young man who said, I have a problem with heroin and I'm sick and I need help. And I didn't know what to say. And, you know, we tried to facilitate some treatments, but what we found is there's not a lot of options. And at the time, we really weren't ready for that. As a children's hospital, we had never really experienced something. This was years ago. And I made some recommendations outpatient and I sent him on his way. And actually, I recommend maybe even go to the Cleveland Clinic. Maybe they could do better. And I think we've come a long way because the problem is we always recognize this, you know, disease, but we recognized it as an adult problem. And I always say there's a lot of moments, if anybody who's in recovery, who's here with us today, who understands, there are a lot of moments you can touch somebody's life way before they come and say, hi, I'm an IV drug user and I need help. And that's if we're dealing with heroin. There's plenty of other substances that have been going on for far longer. So that was kind of my first exposure. And I didn't like saying that I couldn't do more. I thought the role of a pediatrician was to do more to help children. And then I kind of came to this path, which many of us do. So after that, I started working with newborns, and I started seeing more of these babies born in neonatal abstinence, which is the withdrawal. I always say, please understand, these babies are not born with what people describe as addiction. They're born in withdrawal. They didn't have a choice in their initial usage. They were born this way. And one of the questions we had, because we learned from the crack epidemic, is what's the long-term ramifications? And so that's kind of where some of this came from, and kind of saying that Akron Children's needs to fill that void and be part of this conversation now. So I'm thankful that you all have allowed me to be here today. Today we're going to be talking about substance use in youth and kind of some of the grand overarching things. You may have received slides that said something about spirituality. I apologize about that. That was slipped in there from another presentation, and I've taken them back out. Today is not a spirituality conversation, though we could talk for spirituality for hours. I always like to start with my favorite slide. These are all the PSAs, because this is about as far as we went for years and years and years, and still there are some that are out there now for how we dealt with substance use. You know, celebrities telling you don't do the drugs. So you can see all the Clint Eastwood, Michael Jordan, Nancy Reagan. I will admit that I met Telly Savalas as a child, so I'm kind of partial to Telly. And that's as far as we went with it. Don't do drugs. Mission accomplished. Kids will be fine. You know. So again, these are just a little bit of my disclosures. I just want to be clear. I don't work for pharmaceutical companies. I do consulting work. I am the medical director of some adult facilities, Silver Maple, Recovery, River, IOP, Prosperity Haven, and I do some work at Glen Bay Hospital. Again, I want to acknowledge Talia Brown and her excellent work. Some of these, whenever I use slides, Talia has also helped me prepare some of these. And I really want to thank our the Foundation for Akron Children's. This initiative is really helped and supported by our foundation. It was started as kind of a grassroots movement, and they help facilitate our funding. I also want to acknowledge Boston Children's Hospital. Some of these slides are theirs, and honestly, they are the grandfather of substance use in youth, and so I really thank them for all the help and the contribution they've given to us, and the Hilton Foundation and all their great work they've also shared with us. So kind of today's overview. We're going to talk about the disease of addiction. We're going to kind of gain some comprehensive understanding of adolescent brain development and how alcohol and other drugs affect the brain. And we're going to talk a little bit about trends in adolescence. So I always start with the basics. When we talk about addiction, we have to define it. Addiction is a primary chronic disease of the brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits lead to the characteristic biologic, psychological, social, and spiritual manifestations. They reflect in individuals pathologically pursuing reward and or relief by substance use and other behaviors. Addiction is characterized by the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behavior and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction is often involved cycles of relapse and remission without treatment or engagement in recovery activities. Addiction is progressive and can result in disability or premature death. We know that there's a combination of genetic and environmental triggers. Genetics account for about half the likelihood that an individual will develop addiction. The environment factors interact with the person's biology and affects the extent to which genetic factors exert their influence. Other things that we know is presence of underlying biologic deficits in the function of rewards, repeat engagement, drug use or addictive behavior, cognitive and affective distortions, disruption of healthy social supports and problems in interpersonal relationships. We also know that exposure to trauma or stressors that overwhelm an individual's coping abilities, distortion in meaning and purpose and values that guide attitudes, thinking, and behavior. Distortion in the person's connection with self and with others and with the transcendent higher power. Presence of co-occurring psychiatric disorders in person who engage in substance use or other addictive behaviors. The most common things we see is anxiety, bipolar, depression, PTSD, post-traumatic stress disorder, schizophrenia, and antisocial personalities. So saying all those words, if anybody remembers this gentleman, he was one of my favorites. This is the late Sam Kinison. You know, when we really talk about the disease of addiction, we're really talking about the consequences that it has: personal relationships, employment, interpersonal. And so I always love this quote that Sam said, and I do remember him saying this. I said, I called a detox center just to see how much it would cost. $13,000 for 3 weeks. My friend, if you can come up with 13 grand, you don't have a problem yet. And that's kind of what I say. It's all about the consequences. I don't know if people remember this. I actually do, because I was a big fan of his. Sam was mostly struggled with alcohol and cocaine, but in 1992, he was driving his car when he was struck in a head-on collision in California. The pickup truck was actually driven by a 17-year-old. The youth was drunk. Sam was sober. to all our interesting knowledge. So I always say the guy that was in, and he was in recovery. So I always kind of think about where we are. I like to take a moment to kind of talk about, again, talking about these negative consequences and understanding what we do. We've kind of changed some of our terminology, specifically in the diagnosis. And what I'm trying to show you here is we used to talk about substance abuse and substance dependence. And we would try to kind of, based on what youth or adults would share with us, you would fall into these categories. And we've actually, with the new DSM criteria, we've actually changed this into one lump thing. And the reason, and I think this has actually kind of opened the door to understanding the disease more, because the problem specifically when I talk about youth is, if I told a young person that they have a substance abuse problem and they say, okay, so I use this amount of the drug, what's a safe level I can use, doc, where I'm not abusing it or I'm not misusing it, right? It implies that there's a safe level that can do it. And so I always say, so what do you think a safe level of cocaine use is? And they go, I don't know. I go, good, either do I. So let's go with that. That's not going to be the solution to the problem that you can use this amount of a drug. What we know specifically, and we're going to be talking about today, is we're dealing with developing brains, and developing brains have their own issues. So the idea that I can tell you that you're going to get a doctor's note saying that you can use this substance within this limit and everything will be fine in your life, not going to happen in my practice. So I always like to talk about kind of the beginning of kind of how we got here a little bit. I'm a history buff. I always like to talk about the original biopsychosocial illness model that we used to talk about. And we used to talk about this idea that, you know, again, this goes back to some of what we talked about before, but we looked at biology, we looked at psychological, we looked at social, and we looked at use. And there was this idea that if you had this right ratio of any of these things together, or you would flip a switch, the brain switch would activate, and therefore you would lead to a substance use, you would lead to addiction. And so the idea is, if I could fix all these things for you, great, I can turn the switch back off, mission accomplished, we're back to normal, you don't need any more help. And then we kind of figured that, guess what, that didn't work, right? So we figured out there are these things called stressors, we call them relapse, you know, we call them cues, we call them exposure. These all things go into substance use for why we use. If for those who are in recovery who do AA or NA, we talk about people, places, and things. We talk about, you know, my favorite mnemonic, HALT, hungry, angry, lonely, and tired. And I'll ask my patients when they have struggles, I go, which one are you falling into, or which one did you fall into that required that you felt that you had to go use? And you can usually whittle it down. It's not just a straight I just used. You know, there's usually something associated with it. That was the old model. What we've kind of moved, and this is the model that I think of now, this is Nora Volkow. For those who don't know Nora is runs NIDA, the National Institute of Drug Abuse, and she does a lot of the brain models that we see now. And so this is what I like to call the Volkow model. And I do recommend, if you need to hear somebody who's the greatest advocate for the disease of addiction, you can pull her up on YouTube. She gives TED Talks. She was the main speaker at last year's American Society of Addiction Medicine. Nora is a great advocate for the brain model. And personally, she's my hero, and Talia will probably laugh at some point because she knows how I feel about her. She's also, anybody who loves history like I do, she's from Mexico, and you go, how does a person with a Russian last name end up in Mexico? Well, Nora is actually the granddaughter of Leon Trotsky. For those who don't remember Leon Trotsky, he was one of the heads of the Russian Revolution. Leon fled during the revolution and ended up in Mexico. So she will talk about occasionally her alcoholic grandfather who committed suicide in their home, and she's talking about Leon Trotsky. So it's a little bit of history, it's a little bit of interest. So I always say I'd love to have dinner with her and her husband. So, but I digress. But so this is the kind of the model that Nora's kind of developed. And so I always talk about this, I talk about this a lot because I kind of say, we have to look at it a little bit different. People always say, oh, they just use to use, and that's how it goes, and moral failures. But what we see is, I always say that really the only choice you had is maybe the first time. And the first time you got a response from the drug, it did something for you, you used, and then you may kind of go through this withdrawal experience. And so the withdrawal doesn't feel good, you don't feel right. So you start using more to try to kind of get out of that negative, and then you become a little preoccupied with it in anticipation. You kind of end up in this cycle of kind of what I call the cycle of substance violence. You use again to kind of get out of it, you get sick. And then what ends up happening in that process is you're making neuroadaptive changes. You're changing the circuitry of the brain in this experience. And that's kind of why everything kind of runs roughshod and you end up in trouble. So, you know, when people say, my God, did you hear about that guy who was found in the bathroom at McDonald's? I go, he was just trying to get high. And I go, my God, if you know anybody in recovery, they'll tell you they don't get high. They haven't gotten high. Maybe they got high in the beginning. That was the beginning, but things changed for them. They're trying not to be sick. So I say, and so, and especially nowadays with the age of fentanyl, you know, the stuff is not very good. It doesn't last very long. They think they're doing okay. They're feeling okay. And they may go out thinking they got to go eat lunch and go to McDonald's. And while they're waiting in line, they get sick. They literally feel like they have the flu and they go into the bathroom and use, trying to not be sick. The goal is, I go, if you ask most people in recovery, they'll say they wish they could get high. That's not a possibility for them. It's not trying to be sick and in despair. And then unfortunately it becomes kind of this cycle. So I'll leave it there. There are lots of the neurotransmitter, the chemicals of the brains that we think about. And I know it sounds big and fancy, but in the end, we're really just talking about two things. We're talking about serotonin and dopamine. These are the main kind of pleasure substances of the brain. And so I always like to start off with this because this is how I kind of put it in perspective for people. When we talk about dopamine, the pleasure hormone of the brain, this was a study they did in '97 where they basically said, okay, if I give you food, what's your dopamine? How much dopamine is caused? How much is released? And what they found is, okay, just to give you an idea, from where you were before you ate, it went up to about 150 when you had food. When you have sexual activity, you go somewhere closer to 200. So you go, okay, 150 for food. I enjoy food. I enjoy the other thing. It goes up to 200. You know, that's great. Then they looked at substances, and you can see, and this again, remember the time frame we're talking about. You know, when they did these substances, this is from '88. So you're looking at the dopamine surges associated with amphetamines and cocaine. I mean, amphetamines were running in 1,000 with the current methamphetamines that we're seeing on the streets. We're probably closer to 2. When we're looking at cocaine, you're in the 300s. When you look at even nicotine, for example, nicotine goes above 200, and opiates, morphine goes in the 200s. So I always go, when you look at the natural pleasure things of the brain, I can't compete with these substances. I go, we're not built to compete with these substances. So you really have to look, is it worth this moment of pleasure when you're kind of dealing with recovery? Is it worth everything you're going to lose to continue the substance use? And that's a lot of times what we focus on. I go, I wish I could give you a magic pill to make everything better, that I can compete with these things. I don't have anything that does that. So again, that's why counseling, working on coping, you know, going to your meetings, why everything is so important, because I don't have a substance that I can use to replace these substances in a competitive way. So I always say, when I look at substances, this is how I look at it. You know, I say, and I share this photo with many of my patients. I go, isn't that a beautiful picture? That is a beautiful picture, right? These people are clearly in love. And then you kind of look back from the photo and you say, are those trees? Yeah, those are the tops of trees. This couple, this is probably a couple years already. I believe this was in Belize. This couple got into a lot of heat because they were, whatever they are, Twitter people that like to share their visits and trips. And people said, are you crazy? You could have dropped her. They are actually like 3 stories up. These are the top of the trees. This is some infinity pool. And you know, they said, are you guys crazy? You could have dropped her. And the guys, and the couple's response was, I knew he had me. And I go, you're right. He had you. Now try doing that 20 more times. Try doing it 50 times. You are, at some point, you're going to drop her if you keep doing it. It's just a matter of when. And this is how I look at it. I go, if you could keep this love, it wasn't the kiss enough, but it wasn't enough. You had to take it to the next level. And there's a chance something will go wrong. Same thing. This was a couple that came out right after this couple. This was my other favorite one. Same idea. They had to do this beautiful kissing moment. I think this is in Sri Lanka. This was a couple months after this couple. And when they were kind of attacked about taking this, what I consider a romantically stupid photo, their response is, well, the train was going slow. I go, I don't care about the speed of the train. I care the fact that you're on the side of a cliff. But okay, you know, the train was going slow. Again, the reward of the kiss was enough, but the idea that you had to kind of take a chance, I don't know. That's how I look at it, and that's how I talk about it. So really, when we talk about kind of the disease of addiction or substance use, we really look at kind of this is kind of where a lot of us kind of put more of our science into it now. We're looking at the mesolimbic reward system. And basically what it's a combination of is basically what's called the nucleus accumbens through which is what we consider the the reward center of our brain through signals coming from the ventral tegmental area, and then the balance of that is this area called the prefrontal cortex. So we say the nucleus accumbens is this reward center of our brain where all things pleasurable go through, and the prefrontal cortex is kind of a higher functioning developing part of the brain that kind of says, this is a bad idea. This is you kind of got the idea that one part says, let's go do this, and then you got the part of the brain that says, hold your horses, something bad, or we shouldn't be doing this right now, we have other responsibilities. And it's this idea that they play off each other. So you is kind of what leads to the problems. Again, when we look at the reward center of the brain, that nucleus accumbens, basically what I can tell you is every substance goes there. And so I tell my patients, I ask you about lots of substances in our visits. I'll ask them about alcohol, I'll ask them about cocaine, methamphetamines, you name it. I've asked them about it, and then I say, guess which of these substances I care about? And they go, I don't know. The one that I'm using. And I go, no, I don't care about any of them, actually. I care about your brain. And I say, your brain has a problem with reward. And it doesn't matter what the reward is. It's all the same. It all goes to the same part of the brain. It changes that part of the brain. So, I always say, I use the analogy of diabetes. Most people understand diabetes, right? It's a disease of sugar, right? You have a problem with your sugars. I go, you're a diabetic who loves chocolate, but a cookie is still sugar too. So the idea that one substance is okay versus the other, no, it all fuels the same part of the brain. And so my concern is you're going to take one substance into your body thinking it's going to make up for the other substance, and eventually you'll say, you know what, I prefer the other substance. It's what my brain prefers. So saying one thing is safe versus the other, I don't look at it that way. So again, to Talia's point, are adolescents different? And I always love this picture. I mean, this is probably how most of us who have young people in our lives, I have 2 children myself, and different parts of these brains are highly developed in my children. So what I can tell you is, at a very basic level, adolescents are not adults. We keep treating them like they are. They look like adults, they smell like adults. No, they're very different. And so one of the things that we used to think is, well, when you hit adult size, your brain must be an adult's brain, right? I mean, that makes sense, right? You're the size of an adult, you're an adult. Well, so what we know is adult size brain happens around age 10 to 12. Okay, that's when you have a brain that, if I looked at your 2 brains, they're the same size, same whatever. It happens around age 12. But what we figured out is that brain development is not done just because you have an adult-sized brain. So this part is where I like to say, let's talk a little bit about developing. When we first develop, we really talk about the development, we talk about going from the front of the brain, or excuse me, from the back of the brain to the front. So we really deal with cerebellum and the occipital lobe. These really kind of do gross motor function. This is kind of the earliest, the 16-month-old. The other thing is the amygdala. This is kind of your emotional center of the brain. What is the terrible twos, right? There's the kid who gets easily upset because you said no. And then you get the nucleus, you got the reward, right? This is the thing that causes us to love what we do. And, my son gets an A and he smiles. My daughter gets a C and she smiles because it's better. This is the reward center. And then the final part of the brain, and this is the part that people forget about, is really the prefrontal cortex. This happens in the teenage years and kind of finishes developing around age 25. As you can see, this teenager is currently making a bad decision, right? She's texting while she's driving. And that's because the prefrontal cortex is kind of the higher reasoning part of the brain and says you shouldn't be texting and driving. Why? Because you could die from a car accident. And again, that happens in the teen years and finishes up right around 25, 26. So when we look at it, you got the kind of the coordination, the cerebellum, the amygdala for the emotions, the motivation when you get to school age, and really adolescence is this planning, organizing, impulsive, which is the prefrontal cortex. Now we're going to get really fancy and say, okay, now if you look at the brain, remember I said you got brain size, but really what we're talking about is the development of the neurons, the connection points of the brain, what makes us who we are. And what we see is when babies are first born, they have very few neurons. They have if you've ever seen that movie Inside Out, if you really like animated, knock yourself out. But you saw that there was basically one emotion, which then led to 2 emotions, which then led to 4. And by the time she's a teenager, she's got 20. But the idea is you have these very few connections. This is a very basic model brain. And then what happens right around age 4 or 5, you have this, what's called blossoming. You have an explosion of neuron, all these connections. This is why people always say, learn a language when you're young. because kids can do it? And the answer is they can. They have all these connections for that to occur. And then around age 14, you go through something called synaptic pruning, where you actually whittle these back. So you can see where you had heavy growth in the age of 4 and 5, 6. By age 14, you're starting to kind of lock it down. And what's happening is you're pruning it. You're kind of cutting back on some of these things, and ultimately they're actually getting sealed into who your adult personality is going to be. So it's kind of becomes who you are, and that's through a process we call myelination, which basically takes this neuron and covers it in this fatty material and kind of locks it in. And so that's what we see during the young ages. So what you're now seeing is a functional MRI of the brain, and what's lighting up is what we call gray matter, which is this uncovered neuron. It doesn't have that coating on it. And what you can see starting at age 5, the brain is, what you're seeing is all this uncovered brain. It's very colorful. By age 20, it's almost all gone, and you see a few areas that are really left, and really what's left is the prefrontal cortex area. And so what you're seeing is kind of that we're locking into our adult personality. So the idea is, if you use a substance during this period of time, some type of neural inhibitor, so to speak, you are affecting that natural development of the brain. So what we always talk about in general, so why do we do this? The answer is, well, the nucleus accumbens, the reward center, is very well developed, knowing that the prefrontal cortex is the last part of the brain that develops. Really, that area in between the final development is adolescence, which naturally people go, so why do we have this? And the answer is, well, you're looking at man the wrong way. Man, if you think about the caveman's lifespan was very short. The idea that basically the way we look at it is you had a time period in your life where you had to take risk, right? If you lived in a cave with your parents, there came a time you need to move out of that cave, go fight the bear, hunt for survival, and go make your own cave. You needed the ability to say, I'm going to take rewards, I'm going to take chances, but I'm not ready to take risks. We didn't want the risks in the way of kind of changing. But what happens is now is that development kind of gets lost in the mix because now we have such long life expectancies. So what I always tell people, when you look at these reward centers, this was a study done, you can see what they looked at is children under 11, 13 to 17, and adults. And what they looked at is young children specifically, if you offer them a small reward, oh, bring me your shoes and I'll give you a piece of candy, they jump on that, right? But what you see is if I offered that to my teenager, go clean up your room and I'll offer you a piece of candy or something, they go, nah, that's okay. And adults definitely will not accept that deal, And that's kind of what you see here, that they don't take the cue. When you offer something large, okay, so a young child would do it, would have done it for small too. Adults would do it because there's something big in it for them. And teens, I use the example, okay, you can stay up late, you can take the car and you can stay out till 2 a.m. They'll take that reward. So basically what I always say is young people are developmentally primed to seek big rewards. So substance kind of fills some of that. There's a chance with it, but there may be an enjoyment. So really the concern ultimately comes, so why is he talked all about this stuff? Well, what we know is most substances start in youth. So this is a slide that basically says, if you really look at presenting, the younger you are, these are the ages where you get your first exposure. Very few people kind of start illicit drug use when they get older. Why? Because they kind of realize some of the risks related to it. Obviously we could probably have conversations about the opiate epidemic because that had its own kind of problems, which I could talk about that for an hour on itself, and probably more. And what we really know, honestly, so knowing that young people are kind of prone for this risky behavior, what does it all mean? The answer is, well, the younger you start, the more you affect that development of the brain, the more likely you are to lead into a substance use. And so what I mean by that is if you look at this thing, at this data, for example, if you start under the age of 13 using alcohol, there's a 47% chance, it means almost about half, that you will later develop an alcohol use disorder. Marijuana somewhere, and this is older data, about 20%. I would argue probably if we read this study, it's getting worse, but I don't have slides to share like that right now. So what I always say is adolescents are vulnerable. The early substance use increases your risk of addiction. The immaturity of the critical development period leads to vulnerability. Impulsiveness and excitement seeking, they're looking to do some big reward, right? The kiss wasn't enough unless you're hanging off a cliff. Delayed gratification, they want it and they want it now, and they have poor executive function. That part of the brain that says we've got something to lose doing this idea, it's a bad idea, is not fully developed yet. So I always say when we started this project, and now we're a department, you know, one of the things is we were really born out of the opiate epidemic because we said I had experienced it. I said there's got to be something going on. Others had begun to experience the same thing. And so when the hospital first kind of said this, they said, so you're going to be running an opiate clinic. And what I learned, because I again was dealing mostly with adults initially because of my training, is no, that's not a big part of what we do. Youth don't tend to move to those substances. They do them, but not to the same degree like adults do. So one of the things I learned about is something called monitoring the future. Monitoring the future is a study. We've been doing this since '75, and basically they look at 12th, 10th, and 8th graders and kind of look at their behaviors, what substances are using, and what are some of their feelings about the substances. And a lot of times what we see is as the feeling for the substance changes, the usage increases, right? Makes sense. When you don't think there's a problem with marijuana, why wouldn't I use marijuana? These things, these are some of the things. So we get an idea of we get an idea of what the current trends are and what the trends coming down the pike are going to be. This is done through the University of Michigan. I just want to share a few of the slides today. So again, when people said, oh, you're going to be starting an opiate clinic, I said, I'll be dealing with opiates, yes. But that's really not where the main of this goes. What we're really seeing, and this is what this kind of goes, is marijuana is top priority. We deal with some of the hallucinogenics, and you can see heroin's all the way at the bottom. The big thing that honestly is kind of the red alarms in the American Academy of Pediatrics and in young people, we're really dealing with vaping like we did really well with tobacco for a long time, but the introduction of this vaping idea that it's some type of safe nicotine alternative or cannabis use alternative, we've seen basically in the last years that we're just seeing doubling in the vaping form. Not smoking cigarettes, but vaping. So nicotine has become a problem in this alternative form. And binge drinking kind of decreased a little bit, but honestly, in my mind, it's not a significant change. And again, the vaping is the significant climb. That's where most of the push is really going on right now in young people, is understanding that it's just not, it's not harmless. That nicotine is an addictive substance. And again, the other part is THC. We've been seeing significant climbs in that. So I do want to, again, knowing that, you know, when we look at our substances, alcohol and cannabis are kind of our main two, and that's where most of our data is, and that's kind of where we draw some of our conclusions from, saying, well, we know this about alcohol and cannabis, so we can kind of apply some of this to the other substances that we deal with. So again, when we talk about alcohol specifically, it kind of goes to all parts of the brain. We see involvement in the frontal cortex, which is movement, temporal lobe, involved hearing and language, parietal lobe, sensation, occipital lobe, vision and perception, and cerebellum, posture, balance, and coordination of movement. I always love this study. This was the behavioral effects on rats. What they did is they gave alcohol or saline to these rats, and then they ran them through some experiments and kind of saw what they did. And so basically what they found is the adult rats kind of got sleepy when they used alcohol. They decreased their movement by about 47%, about half. And the adolescents kept on going. I don't think they were really doing that dancing, but they were very active versus like the adult mouse who just wanted to take a nap. When they did this, one of the things they did was what was called the water maze test. And basically what they do is they took adolescents who used alcohol, adolescent rats who used alcohol and then or was given saline. And the other group was the adults, same thing, were either given alcohol and then or they were given saline. They were thrown into this water. And the idea is there is a way to get out of the pool. There's I forget the term I'm looking for, a platform. It's submerged. And the goal is they had to swim and find the platform and get out. And what they basically found is the adult rats, they swam slower and they had a hard time finding the platform, okay? When they looked at the young adolescent rats, guess what? They swam at the same speed. Like I said, movement was not impaired, but finding the platform was. So the idea is there's this misperception that young people, right, because you don't have some of the motor impairments associated with alcohol, that you're okay. But we know that your time to platform, your time to respond, right, is still problematic. So it's not a harmless substance for young people. The other thing that we've also seen, another study looked at the impact on the hippocampus. Hippocampus, for those who don't know, is kind of the memory center of the brain. And this was specifically done in young people. And what they looked at, the size of the memory center of the brain, and what they looked at is a group that were diagnosed as an alcohol use disorder in young people versus healthy controlled teens. And what we saw is they had smaller hippocampus, so they had some memory impairment associated with their chronic alcohol use. When we looked at marijuana, and for those who don't know, the psychoactive substance of marijuana is the delta-9 tetrahydrocannabinol, or THC. It's a psychoactive, it's fat-soluble, blood-brain barrier, accumulates several days to a week, acts on the endogenous cannabinoid receptors present in the central peripheral nervous system. This is the one I focus a lot with my young people, because they go, well, it's a plant, so it must be good, right? Or organic is the new thing, right? I go, yeah, I still know a lot of healthy people that eat vegetables, but that's okay, you know. Or unhealthy people, I should say. But basically what I can tell you is we've only in the last, 30 years or so really kind of get some greater understanding of cannabis, in the sense that in '88, we actually discovered the CB1 receptor through Howlett and Devine. By 1992, there was a group in Israel that had discovered the hormone that was connecting to that receptor. It's called anandamide. It means bliss. But what I always tell my young people is, look, the reason why it took even longer to find that, the chemical, is we make almost none of it. So just to give you an idea, anandamide is a natural produced hormone. This is THC. Chemically, I'm being told that they look identical. I'm not going to lie, organic chemistry was not my strong suit. What we really know about THC is these are the parts of the brain that it affects. Specifically, it's affecting memory centers. We also have motor coordination, digestion, emotion, pain. All these things kind of go together. And I always ask my young people, I say, they go, oh, it helps my anxiety. I go, great. Do you know how it helps your anxiety? And they go, no, I mean, you use it and it helps. And I go, great. I go, anandamide, or this endocannabinoid system, how it works is it kind of acts as a dial system. So I go, you're right, it will help your anxiety. It will decrease the dial. The problem is if anybody's ever messed with the thermostat in their parents' house, don't touch the thermos. So when it gets too cold, the parents just crank it right back up and they make it hotter. That's how this works. When you keep adjusting the thermostat keeps, you turn it down, the thermostat says, okay, don't touch me again, and now they wrench it back up. And so it affects all these other things in the processes. So it affects mood, pain, pleasure, motivation, because it's an adjuster of the systems. And so the other part is we know it also plays a role in shaping brain development. So it helps guide those neurons to grow in the right place and controls the activity of those brains. So it actually helps support that protective coding development on neurons. Now, I'm going to put this in perspective, and I apologize, I know I talk for a long time, but this was a study done in 1999. And what they did is they looked at, okay, so if cannabis, or THC, the psychoactive substance, looks a lot like anandamide, what does it really look like to the brain? And the answer is the connection to the brain. THC runs a connection rate of about 1, meaning strong. Anandamide is what's considered a 0.47, which means about half the strength of THC. So I want to keep that in perspective when I kind of present the next slide. So saying that the natural substance only wants to really work on the brain about half the strength of regular THC. This was done, what I say, in 1999. This was one of my favorite slides I like to show to young people. And I said, this was a study done, it completed in 2014, and it was published 2016. That looked, every time the DEA, the Drug Enforcement Agency, made a bust, they were testing the concentrations of THC. Before 1995, all THC in this country was less than 4% THC. So when this study was done, we were looking at less than 4% THC. By 2014, through selective breeding, we were up to about 12% THC, and this is in plant material, okay? Now with the selective breeding that we see in 2020, we are somewhere about 30 to 40% THC that we're seeing on the market. And with vaping and dabs and all these other concoctions we've come up with, I have patients, you can get 90%. I have patients telling me they're getting 100% THC through other materials. So I say, great. 100% on less than 4%, imagine what it's doing to your brain now. This is not the same. I always make that argument. I go, when Willie Nelson talks about his marijuana, I don't think he's talking about the same marijuana now. I think he's talking about something very different. And so again, what I tell my patients ultimately is where you needed a gentle, a very precise procedure done to help to change your brain, you're taking a sledgehammer and just whacking the whole thing. So that's kind of the best analogy I ever heard. It's a sledgehammer versus a scalpel. You're doing something completely not surgical to try to treat your symptoms. The other things we know, same thing, the hippocampus, we see reduced hippocampal activation. We see gradual loss due to continued suppression. And we've seen THC users have small hippocampus, so they have poorer memory. And the question is, so if I stop using, will that get better? It doesn't look like it. It looks like that might be a permanent loss. Again, we've seen neuropsychological decline from child to midlife, and we've seen that associated. One of the studies that kind of put that in perspective is a study called the Dunedin study. I always like to share this one. For those who don't know, Dunedin is a small town in New Zealand who was originally doing a developmental, it was designed to be a developmental study. They were only supposed to go for about 3 or 4 years looking at the babies born at this local hospital and looking at their development. And I always love science. Somehow they kept finding funding. And so Dunedin has still been going on to this day. The original participants, we are now looking at, they have now started wings of the study to look at their children. And so we have this kind of long-term longitudinal assessments that they've been doing for their age. And one of the things they looked at was substance use. So one of the things that Dunedin has kind of shown us is that if you've never used marijuana, these are your average IQs. These are normal IQs, 99.8 to 100.6. If you, what they consider marijuana dependent, which is basically saying more than three years of usage, we've seen people lose almost about 10 points of IQ compared to where the group that never used. And again, this does not look like something we're going to get back even after you stopped using. Again, the psychoactive affective mental health outcomes that we've done lots. There's evidence consistent that cannabis increased the risk of psychotic outcomes independent of co-founding transient intoxication effects, that there is long-term changes to the brain. People always say, oh, that's just one study. I go, no, sorry, there's about 6 of them. And they've all done, and basically what you see is these things called odds ratios. And part of the reason why you see such a difference in odds ratios is people try to argue, oh, well, these were people that had mental health in their family already. So they were kind of predisposed. The substance just tipped the scale. Yeah, so depending on which study you look at and which group in the study you looked at, they've actually looked at this, where if you had no family history of mental health, your odds ratio is about 1.56 or 2. So you have twice the chance from chronic usage of having some mental health. If you have the family history, you might be more like 6.81, about 7 times more likely to have some type of mental health disorder related to your cannabis use. So saying it's benign, I wouldn't say that. Again, this same thing, this is my favorite of all these studies was, this is the Swedish study. Sweden, I love it. I love studies that are complete accidents and honestly expose some government issues in the process. This study came out of, what they did is, this was Sweden had mandatory conscription to the military service. And one of the things they did is they did a substance use history. Well, once the person did their time, they were supposed to destroy the data. And somehow a box got left around. They had like 30,000 of these studies done. And it was like 30 years ago. It was an old box, found mildew, whatever, you name it. It was supposed to be destroyed. The beauty of it all is it's mandatory to do military service. Substance use does not eliminate you from substance use. Substance use does not eliminate you from military service. And if you were honest, which most of the people seem to be, it wouldn't change anything. So you had no reason not to be honest about your usage. And so basically what they did is, okay, then they have like a government healthcare system. And then so what they did is they pulled up these people and looked at their substance histories and said, okay, how many of these people have come in for mental health and other related health issues over the years? And then they could track it through the healthcare system. So they were able to basically put together 30 years of data because they had this data set from when they were 18 years old, and 30 years later, you can see all these people and how they struggled. So this is where this data came from. The other thing that one of the reasons why, and we're seeing more and more of this, especially in young people, is this cannabis psychosis event. And one of the things we're seeing, and one of the theories behind this is, what you're looking at is the corpus callosum of the brain, this very colorful part of the brain, is the connection point between all the signals coming from the right side and the left side of the brain. And when you look at patients that struggle with schizophrenia, what we see is a thinning. You can see very little coloring here. And when you see daily marijuana compared to this healthy non-user, it's thinned out. And so one of the theories is maybe this is why we're seeing some of the schizophrenic-like tendencies in heavy marijuana user, is that it's affected the size and shape of the corpus callosum, which is basically sending signals from either side of the brain. So again, if I had to leave you with it, basically marijuana regularly loose somewhere between 2 to 5 times of developing a psychosis, schizophrenia, anxiety, or depression into adulthood. Past prevalence of marijuana use, this just basically shows you, basically we're seeing increase there. Oh, this is the slide that basically says, you know, people think, well, they're just doing marijuana. A lot of times young people, they don't stick to one substance. So what we see is they tend to use other substance in accordance with their marijuana use. They're not just smoking weed, they're also using alcohol and cigarettes. Again, long-term, we know marijuana use causes psychosis, depression, anxiety, diminished life satisfaction, cognitive decline, and substance use disorder. So I leave you with, can you please stop pretending marijuana is harmless, especially for young people? That argument needs to go out. I will acknowledge the group in the room that may say we're pro-support for legalization, but if you ask what I consider some of the experts in that field, they will say young people should not be doing this. But that kind of gets lost in some of the conversation. So the other book I do recommend, which is kind of a long-winded version of what I've talked about today, is Tell Your Children by Alex Berenson. I think it does a wonderful job kind of painting the picture of marijuana legalization versus decriminalization and some of the negative effects it's had in our culture. I also want to leave you just with this expression: you see a heroin, you see heroin, I see low self-esteem. You see cocaine, I see fear. You see alcohol, I see anxiety. You see track marks, I see depression. You see a junkie, I see someone's son. You see a prostitute, I see someone's daughter caught in addiction. You see self-centeredness, I see the disease. You see a pill hell, I see overprescribed of opiates. You see someone unwilling to change, I see someone who hasn't connected with them yet. You see denial, excuse me. You see someone who hasn't, you see denial, I see someone hurting. You see someone nodding out, I see God showing us they need help. You see the end, I see the beginning. You see a dope fiend, I see the future success story. You see them, I see me. For anybody who's interested, we'll be happy to send you flyers for our program. Just these are our emails for Talia and myself. And then one of the things I share with all my patients, and I thought I'd share with you all at the very end, is I describe myself in my career, I always say I'm more of a spiritual doctor than I am kind of a medicine. You can kind of get the idea that I wish I could tell you I have great medicines. I don't. I like to consider myself more of a spiritual doctor. And in that, I think of someone who kind of, in my mind, is the greatest example of something like this. And I always say, do you know what a Sherpa is to my patients? And for those of you who don't know a Sherpa, people know Sherpa as a coat, but Sherpas are actually the mountain climbers who help you get up Mount Everest. So when I talk about treating patients, I say, we're going to climb this mountain. But guess what? I'm not going to carry you, and I don't control the weather. Sometimes we're going to come down because of the weather. Sometimes we're going to go back up, but the goal is always to get to the top. My favorite Sherpa is the original, what I think of the greatest Sherpa of all time, which is Tenzing Norgay. Tenzing Norgay is the Sherpa who helped Sir Edmund Hillary get up Mount Everest. So I leave you with this quote: I have climbed my mountain, but I must still live my life. So here's our phone number. If anybody needs to reach us directly, we're always willing to help anybody. We get lots of phone calls even for people who are not talking about their children, but are looking for some help for a loved one, an adult. We're happy to kind of help point you in that direction if we can't help you with our department. So with that, a few websites of interest. Like I said, I'm happy to, I believe we shared these slides. If anybody's interested, you can see all my references. And that's what I got. I know there are probably questions.
Yes, yeah, we've got some questions. So one of the first things, thank you so much, Dr. Goldman and Talia, for this presentation. I wanted to ask about, we talked about how this impacts the brain. What are the long-term, you talked about the mental health around marijuana, but is there anything, with the other substances, or what people can do to either reverse or create a healthier brain afterwards? What's some other things that people are looking at long-term effects, maybe not just from marijuana, but from
So
alcohol
again,
use?
so when we look at the substances, again, that's why I say I try to de-emphasize substance and I really talk about brain development. The real issue is, yes, you might have lost some IQ points. Yes, there's an increased risk of mental health, but really, and that's why I say I wish I had so when we talk about medication specifically, we're trying to help most of the symptomatic kind of things, anxiety, depression, secondary, either from either your primary mental health or you have substance-induced issues. The other part really then becomes really learning how to live and how to cope, kind of. As we talk, even with patients with chronic pain, we may not be able to get your pain to zero, but we'll learn how to cope with the pain so it doesn't affect your functionality of life. And that's really what we work on. So when we talk about treatment, and Talia can always speak to this to a greater length, we're really trying to teach people how to improve the functionality of that prefrontal cortex so that they can make proper decision making. Like I said, wherever that substance use began is where that part of the brain probably took a developmental hit. And so again, we may not be able to get IQ points back, but if we can teach you how to learn better coping skills so that you don't make the substance the primary driver of your existence, that's kind of the same thing we do with adults. That's why, if you deal with residential treatment, that's basically what we're dealing. People go, all you want to do is talk to me all day, right? Because we're trying to help you learn skill sets that you don't currently possess. And that's why people talk about recovery as a lifestyle, right? Because when you stop practicing a skill, I can tell you right now, I can't do algebra anymore, but my son's asking me for help. If I did it every day of my life, I'd know how to do algebra. Same thing, we're trying to help you to walk that path.
Yeah, that makes sense. That's great. Thank you. Is there some considerations that a family member should have if they have a loved one that started use at a young age? And knowing how that impacted them and how they may be, approaching the world and things like that today, if they're still in their substance use?
So the concern is if a person who's in recovery who has a child using, is that the question?
I had a question beforehand about somebody who has an adult child, but maybe they started using young.
Yeah.
And I think you spoke to a lot of it, but I just didn't know if there's any other considerations.
Yeah. What I say is, because I still work with adults, the funniest thing about my career is I didn't like teenagers when I started training. I thought teenagers were, they wanted to be adults, and I like kids because they were cute. The interesting thing is, I think what's made me a good addiction medicine doctor is because a lot of my adults act like teenagers, and so I can understand. So the answer is, wherever you started using, again, you took that developmental hit, and really in that prefrontal cortex, that higher functioning. What we're talking about is you really have a very active reward center of your brain with no ability to stop that part of the brain by saying, I know you want to go have a good time, but you have to go do your job, you have to go be a father, you have to go do all these things. Hold your horses. That part of the brain took a hit. And so trying to understand long-term, that's why that's really the mainstay of treatment in this country, is trying to work on learning how to get that part of the brain more functional, in my mind.
One
Talia,
thing I
did
would
you have
add,
something to add?
yeah, one thing that when we're talking about addiction and working with adolescents, like, this is truly a disease that impacts the whole family. So we often recommend Al-Anon and Alateen for like any siblings to get them the support that they need, get them connected with people that they can relate to. Enabling is a big thing that we come across when we're dealing with adolescents as well. So just figuring out what supports are available for the patients and family, Al-Anon being huge.
Yeah, one of the hardest things for us in dealing with substance use in young people is they haven't reached the consequences that drive people into recovery in the first place. So there's a lot of because they haven't lost a job. So most of the time, a lot of the young people we see, if you had to say, what are your consequences of your substance use, they will describe their relationship with their family, but they don't you know, their friends are using, why can't I use? You know, it's they haven't lost their job. In fact, I had a young person today say, you know, she was using she wasn't using marijuana, but her employer thought, oh, she's just using some marijuana, and that's why she wasn't. I always say, even in the adult world, people don't realize. Everybody thinks it's when you lose a job that's when you've kind of hit the bottom or something. And the truth is, job is usually the last thing that takes a hit. If you ask most of my adults in recovery, you go, you know, and they're living with their parents or something, because, you know, that's where they have to be. You go, when did you know there was a problem? And they can say, I knew early on, when, you know, because they're sensitive to that. They just either tell people or you don't, but they kind of, job is usually the last thing that takes a struggle, takes a hit.
Yeah. Thank you for that. Is there a recommendation of a good presentation or education for the adolescent brain concept? Someone's asking to incorporate into treatment. They don't want to recreate the wheel. Is there any like video or other presentation references that you
I always recommend Nora Volko.
Okay.
So if you go to NIDA, the National Institute of Drug Abuse, so it's NIDA.gov, I think, is the website. Anything Nora does is, I mean, she's really been the greatest advocate of this. If you can find on YouTube anything, Sharon Levy shared, like I said, a lot of these slides came from Sharon Levy in Boston Children's, so they've been the pioneers in youth substance treatment. But
okay, and I'll share
those
that.
are kind of the big, yeah, and those are kind of the big ones.
All right, I'll share that in the follow-up. We just have one last question, and then we will wrap up. Someone asked if the family members of, and Talia, you kind of referenced this of some resources you recommend, but is there education done with the family members on how to set up a positive environment for sustained recovery with those that you're working with?
Yeah, I think that's something that we address in family sessions. I think with adolescents, and since we opened the clinic, one of the biggest obstacles that we run into is getting the parents on board with not using marijuana in the house, around the kid. So just during family counseling, helping families and patients understand like what things can we put in place to help support the adolescent on the journey to recovery, including making sure that they have a sober home environment. And again, Al-Anon, I can't stress that enough, but yeah, that's something we work on in family counseling.
That's great. Alrighty, well, thank you both so much for taking the time. We've gotten a lot of positive feedback through the chat and the Q&A, and just people are just so grateful for this information. And so I will be sending out a follow-up tomorrow. Barbara, do you have any last thoughts?
I just wanted to thank you guys. I mean, it was an excellent presentation of just sharing the perspective from the adolescent brain, and I thank you guys so much. Encourage everyone, I think this is one of the ones, at least for me, be thinking through it. If you think of any additional questions or, I wish I would have asked, please send those over to Bethany or myself, or even just info@relink.org, and we will be happy to relay them to Talia and Dr. Goldman. I think it's just an excellent presentation with some wonderful information. So thank you both very much.
Welcome.
Thank you. All right, have a great day, everyone. And I will be sending out follow